So now it's my pleasure to introduce the second session on innovating for clinical excellence and improved outcomes. So we have a great speaker lineup as well as a moderator here. So I'd like to now introduce our moderator who will tell us a little bit more, Dr. Keith Morse, who's a clinical associate professor of pediatrics here at Stanford. Thank you.
Good afternoon. Thank you all for being here. We are lucky to have three panelists join us today who are going to be sharing their work on deploying AI to improve clinical excellence and patient outcomes. They bring expertise in, respectively, cardiology, emergency medicine, and pathology. Each is going to give you a brief 10-minute presentation on their work, followed by questions from myself and you all in the audience. As Serena mentioned, I'm your moderator, Keith Morse. Up first, we have our cardiologist, Dr. Fatima Rodriguez. Dr. Rodriguez is an associate professor and section chief of preventive cardiology at Stanford University. Her research interests include racial and ethnic disparities in guideline adherence, personalized risk prediction, and leveraging of digital health tools. Dr. Rodriguez.
Hello. Hi, everybody. Thank you so much for the opportunity to present. Thank you for the organizers, and thank you to AIMI for generous support of our research program. As the slides get uploaded, I'll just tell you that the topic of our work is really around how we can use artificial intelligence to use information, harness it, information that's already sitting in our imaging repositories and electronic health records. And my major disclosure is that I'm not a computer scientist, but I work with really smart computer scientists. But I am a cardiologist, so I think a lot of the problems that we're trying to solve are around getting the right treatment to the right patients and treating people before they have heart disease. So I'm a cardiologist, and cardiology is heart disease is the #1 cause of death worldwide for men and women, and we've had a lot of advances in how we treat heart disease over the years, and that has really resulted in a reduction of cardiovascular disease deaths over several decades. But we can see this uptick in the graph shown here, and a lot of that is because people are having a lot of risk factors that are underdiagnosed, and particularly in vulnerable populations. But one of the reasons I'm a preventive cardiologist is that 80% of heart disease is preventable when you identify those at risk and promptly begin treatment. So how do we assess cardiovascular risk? So there's traditional risk factors that we know, such as having high blood pressure, high cholesterol, but many of the individuals that present with a heart attack do not know they have those risks. So sometimes in clinical practice, we rely on a tool called a gated coronary calcium scan, which again is timed to the beating of the heart. This is a specialized type of chest CT scan without contrast that is available for an out-of-pocket cost. There's been a lot of data, all epidemiological data, showing a robust association between the amount of calcium quantified in the coronary arteries in something called Agatston's units. You can see this graded relationship. As that number goes up, the risk of having a cardiovascular event goes up as well in a graded fashion. And this has been shown across diverse populations. It's a very powerful tool. And also visualizing coronary atherosclerosis for a patient can really help motivate behavior changes and adherence to therapies. But what's the issue? The problem is that these kind of specialized CT scans are not covered by most insurance plans, and patients have to pay an out-of-pocket cost. I do have to throw a little bit of shade at Stanford right now. We have a very high out-of-pocket cost for this of $425 here. So you could imagine that for a lot of our patients, this is just not an accessible tool, especially if they're primary prevention, meaning they have no cardiovascular risk factors or come from underserved backgrounds. Additionally, many of the patients that seek preventive care are not from diverse backgrounds, and there's actually less accessibility to these type of scans across lower socioeconomic populations. So we've been partnering with a group called Bunker Hill for several years to try to work on using an algorithm that can very accurately quantify the amount of coronary calcium in non-gated chest CTs. So these are CT scans that are done for other reasons, such as looking for lung pathology, follow-up for lung cancer, staging or screening, and other types of pathologies that, again, are not cardiovascular related. And in our clinical practice, we often open these kind of scans and try to see, can we visualize hidden plaque in the arteries of our patients? And this algorithm has really excellent performance in detecting the prevalence of coronary calcium and again, can really be used as a tool to look through a large volume of data existing in our radiology records. Something that I'm very passionate about is how can we use this to really improve health equity across our populations. And when we look, this is data from Stanford from the past year, looking at who gets a gated coronary CT scan versus a non-gated scan. We can see some clear differences in the two populations, with more women getting non-gated chest CTs, more people with a Hispanic ethnicity, Black race that are Medicaid insured. And these individuals notably have very high cardiovascular risk, yet very few of these patients, less than a quarter, are on statins, and that's something that's recommended by our heart disease guidelines. So this allows an opportunity to identify patients at risk who may not know it. We've done some epidemiological work, and this has been work led by one of our students, Allison Peng, showing that this deep learning quantified coronary calcium in non-gated chest CT scans can very accurately predict your risk of cardiovascular events and death, again, in the same graded fashion as a dedicated gated CAT scan. And again, very different populations than those who get gated CAT scan with a high prevalence. Again, these are patients without known coronary disease of over 50% of at least some calcium in the coronary arteries. But I really think that the innovation in this tool is how do we implement this in our clinical pathway? We heard a lot about today and yesterday's meeting as well about implementing things in our clinical workflows in ways that make sense. And that's really the set of studies that our group has been working on for several years now. And I'll tell you a little bit about our first project, which is, can we use incidental coronary calcium that is quantified through this artificial intelligence tool to guide preventive therapies? So this is a schematic of our first study called the Notify-1 study that was led by my colleague, Dr. Alex Sandu, Dr. David Marin, and a large group of individuals. And what we did is that we looked at a bunch of CTs in the healthcare system at Stanford, non-gated chest CTs, removed anybody with an ASCVD diagnosis or known history of coronary disease, and then identified those individuals that had a presence of coronary artery calcium. These were then manually reviewed again by Domenico, I have to give him a shout out, who was one of our postdoctoral fellows and is now a radiologist at UW, again to personalize the images, and I'll show you, to notify the patients and the clinicians. So the randomization was to notification versus no notification, and the primary outcome was use of statins. So what did we do? Again, every single image, again for these selected patients, we created a personalized image of their own chest CT scan with a big red circle, so you don't have to be a radiologist to know that that is calcium and it should not be in your arteries. We first notified the primary care clinician, again with just a letter through Epic. This was done as a quality improvement study saying, your patient who had this CT scan historically for other reasons has coronary calcium. According to guidelines, you should engage a discussion with your patient about considering initiating statin therapy to reduce their risk of heart disease. And if we don't hear from you in 2 weeks, we will also notify your patient via Epic in a similar fashion. And you can see this is a little bit just friendlier patient language, but this is a personalized image of the patient's heart scan. And again, we said, all the intervention is notification, have a discussion with your doctor about starting therapy. And what did we find? We found that although these individuals had a very high risk, in 6 months, only about 7% of them started statins. Whereas with this relatively low-touch intervention, we saw that over 50% of those notified started statin therapies. So very dramatic effect size. We also saw that these individuals had better control of other cardiovascular risk factors, better blood pressure control, more engaged visits. And again, something about visualizing coronary calcium was a very powerful motivator. And even more notable, we just looked at this data that at 18 months after notification, we have found this very high persistence of statin use. And this is a big public health problem when patients discontinue this therapy that should be essentially lifelong. We've now also moved to looking at patient and clinician perspectives with focus groups, with help and assistance from the evaluation science unit. So what are our patients and clinicians saying? There's a lot of discussion about how individuals feel toward having artificial intelligence kind of as an intermediary in their care pathway, but in general, perspectives have been positive. There's some concern about patient data use and privacy, which again, we've discussed in this conference. And there's a balance between efficacy and also acceptability to patients. So we're now working to try to optimize our interventions so that they don't cause unnecessary stress, but can maintain the level of efficacy. And importantly, our patients really want there to still be that doctor in the relationship. if you're notified of a finding like this, there should be an action step. What do I do next? How do I feel empowered? How do I have agency? And I just want to introduce everyone to Doug. So Akshay's in our study team, and others know him very well. This is a patient who joins all our meetings. We have him writing grants. We have him writing papers. His name is Doug. He's a semi-retired plant breeder who many years ago underwent a non-gated chest CT for follow-up for a thyroid cancer. And what happened? He wasn't notified until many, many years later when somebody said, hey, remember when you had that CT scan? You actually had severe 3-vessel coronary artery disease and you were not notified. So Doug tells us that he's really excited about the opportunity to have technology help patients feel empowered and prevent heart disease. And again, he's an active member of our group. And this is just the beginning. So we know that this technology can help us in other cases. For example, this is low-dose lung cancer screening CT scans, and the algorithms are being refined to, again, be able to quantify calcium in these scans that are done in patients with very shared risk factors. We just heard this morning about the power of large language models, and our group is very interested in, can we use the narrative portion of clinical notes to identify patients who may be vulnerable to medication non-adherence? Again, I'm a cardiologist. We order this test all the time, an electrocardiogram, growing data showing that something as simple as this widely used technology can predict disease before it manifests. And again, my colleague, Dr. Chowdhury, and others are looking at not just coronary calcium, not just atherosclerosis, but total body composition. And can we predict not just heart disease, but also other chronic diseases before they manifest, and using data that is already there. So in summary, artificial intelligence is really a tool to help us in cardiovascular disease prevention, but it's not a standalone solution. The workflow is very important. Incidental calcium can be very accurately quantified using algorithms, and the notification can drastically improve treatment. But as we think about the implementation of these systems, we really need to think about health equity and how it interacts with our workflow for our clinicians and for our patients. I like to just acknowledge that this is a huge team effort, and this is really the most fun part of this project is the team science. You can see we have people from TDS, from the hospital side, and the AIMI Center as well as the Evaluation Science Unit. So thank you so much for the opportunity to share our work, and thank you to AIMI for funding our work.
Thank you. Up next, we have Dr. Yiadom. Dr. Yiadom is an associate professor of emergency medicine at Stanford University. Her research focuses on applications of evidence-based medicine to optimize clinical operations for time-sensitive conditions with an early application in STEMIs or heart attacks. Dr. Yiadom.
Good afternoon, everyone. I'll just wait a moment here while the slides come up. I wanted to thank everyone here and AIMI HAI for the support that we've had over the several years. A good amount of this work has been funded by the National Heart, Lung, and Blood Institute, but really with seed work and early stage results generated from funding from the organization running our session today. And want to underscore the importance of that early phase funding and support to be able to generate the creativity around the methods for how to move larger volume work that really can demonstrate that there are outcomes for many other folks. And so, as was mentioned earlier, I'm an emergency physician primarily, and so the approach that my team has taken to using AI in the clinical environment it reflects that perspective, much like Dr. Rodriguez's teams. And specifically, I'm a physician scientist. I run a laboratory that focuses on studying the effectiveness of novel clinical interventions so different ways that we can make patients' clinical need for emergency care with other extensions into other practice areas. And the other side of my lab also works specifically on the implementation of an artificial intelligence algorithm, really designed to address a problem that we've had in emergency medicine practice that is definitely generalized throughout the United States in emergency departments that anybody here could potentially walk into. but also as we're learning internationally with applications in developing countries where we're expanding to look at how mHealth or mobile health, mobile technologies can help us replicate some of the work that we're doing now. And so just to, without going into all the clinical detail, did want to give you an overview of what we're working with. So the clinical care problem that we're really addressing is screening to diagnose. So in the emergency department, people come with symptoms. Nobody schedules time with us. We do see some people frequently, but usually they're coming with something brand new each time. And what we need to do from those symptoms and presentations and concerns that people will have is try to figure out what the diagnosis is within minutes to hours. For this particular case, we need to, which is the spectrum of heart attacks, which we refer to as acute coronary syndrome. We look to get a diagnostic test within 10 minutes of arrival. This is really tricky for a couple reasons. One, heart attacks present along a spectrum. We're primarily looking urgently for the most severe form, which is called a STEMI. And of those, we only know that it's a STEMI once we've done the test. And since the test needs to be done in 10 minutes, the test is being done before the patient has seen a physician. So lots of things are backwards from how medicine is generally practiced. As a result, we need to have proscribed protocols that are established in the emergency department for the front-end staff to follow to help us with this. So the screening has to happen at ED arrival intake because the intake clerk is the only person who reliably encounters the patient within 10 minutes. So any patient who's suspected of having a heart attack in healthcare guidelines, and this is across cardiovascular, cardiology, emergency medicine, and in many countries around the world, the general consensus is that we really want to have patients who are suspected of having STEMIs based on their presenting symptoms jump queue from our typical care pathway and get this electrocardiogram, the EKG, which is the diagnostic test. And so there's this early judgment that's made. So a couple things about this early judgment. This is a life or death decision. Mortality is between 25 and 40% when STEMIs are untreated. And time matters. Every minute matters. And for many of us in clinical practice, we've heard the term time is myocardium, time is heart muscle. So every minute really is leading to the potential irreversible damage to the heart muscle. And we have many treatments. Stanford, like many other centers, has the incredible treatment available. That was a novel intervention that happened about 30 to 40 years ago, percutaneous coronary intervention, along with some adjunct medications. But for STEMIs in particular, the treatment is only effective up to about 90 to 120 minutes. So every minute that passes by, if this patient is missed at this screening point, sits in the waiting room for the hour it might take to see the doctor, we very well may have nothing to offer them, and have now had them in a category which is leading to higher levels of death, and amongst survivors, heart failure, which, as many people who are involved in healthcare know, heart failure leads to extensive use of healthcare costs in system and a decrease in the quality of health. So minutes matter, and this front intake screening process really does have a lot of weight to it. And so just to illustrate how patients are coming to us and where we found an opportunity to intervene with AI, again, patients are at home having symptoms. There are several different pathways that they could take to eventually seek care, generally because of guidelines that are recommended for getting urgent diagnostics, which is what we specialize in the emergency department. They're referred to the emergency department and can come in via ambulance or walk themselves in. And then once they come in, they have this encounter with a registration clerk. Generally, they're not this happy, though. But nonetheless, they have this encounter with the registration clerk where the functional administrative activity is to ask who the person is, what they're there for, identify if they've been to the health facility before. If they have, their existing record is brought up and a new encounter is created that is joined with that record. So we have access to all the prior information. If they've not been seen by the care system, we generate a new record for them along with an encounter for the day. And their physical presence in the emergency department tracks with this electronic presence. We do our work in the EHR for them. And so we need this as the first step before we can really deliver care. So along with that intake practice, the clerks are taught that they should also screen for certain presentation symptoms and demographics where people should jump queue for an EKG, which is really important because if they're identified for an EKG, they will jump queue. That EKG will be taken immediately to a physician. The physician will interpret that ECG. This is their first evidence the patient's been in the emergency department. And then they will After that step, they will then go and see the patient if it looks concerning. And so now the physician has gone to the patient because of this intervention. Otherwise, they'll wait for care and evaluation. This is really important because we found that this particular step is where there's an opportunity there's pathophysiology here in the quality of the screening that happens at the step that leads to delays in care that leads to poor clinical outcomes. And so screening really impacting diagnosis and impacting treatment. So really the gap in care that we identified was done through several clinical research studies, and I'll talk towards the end about our pathway. But first, the way that we've been able to create an algorithm or process that clerks can follow is to keep it simple, because they're not clinicians, they're not there to do that. And so, but what we found is that the simplified process we use leads to many people who have heart attacks being missed. So nationally we track medians, but those medians only tell you what's happening at the 50th percentile. We've seen that up to 37% of patients don't get their EKGs on time. And that when you look at who is in that far right-hand side of the curve, you can see that we have a lot of already vulnerable populations that fall disproportionately in that delayed care pathway. So we looked to see what data was available at this particular point in care. So using huge data sets and external data sets was really not relevant for this particular scenario. We were looking at routinely collected data and trying to mathematically optimize a prediction that can supersede what humans are able to do. So just to share some of our results with you, as you'll see here, the gray line is what human practice currently looks like. We practice as if it's 100%, clearly it is not. What we first did was we had a base model, which is at the bottom. You can see it is the dark green. The base model actually made two groups, particularly Black patients and Native American Pacific Islander patients. It made predictions worse in those groups. It was not appropriate for deployment, despite the model overall improving better, performing better than humans. And for this particular case, because we will do lots of EKGs as long as we can capture all the right patients, sensitivity was the right marker, which was a little bit of a battle with our data scientists who really wanted to use area under the curve and really explaining how sensitivity and specificity were not equivalent in this clinical scenario, and therefore that was not the right metric to measure the model's performance. And then what we did at the end, you could see the two blue lines, is we actually took the models and realized that the humans were actually more equitable than the model was. The model was actually exacerbating disparities. So we realized our initial intention to deploy this instead of the clerks and have the AI make the decisions, we actually joined it with the clerk's activity. So it works as a fail-safe where within milliseconds, if they don't respond, it responds for them and does activities we normally would rely on humans to do. So one of the key takeaways from this was that even with our best performing model, where the humans and our diversity sensitive model at the top had really improved performance, there was still variation in terms of equity. We realized we actually had to have separate coding from the model in order to tell the model how to be equitable. The model was doing exactly what it was designed to do. It is replicating the reality of our world, trying to make predictions for outcomes that are biased. It's not having any issue. It's not really working against anybody. It's doing exactly what it was designed to do. So what we ended up doing was creating additional coding separate from the model to tell it how to act equitably. And these are some early results as of last week, but we're able to find this performance where there is no variation, or there's very minimal variation across groups. And as you can see, what was really helpful for the clinicians making decisions about what threshold to pick in terms of how well the model performed, we had to tell them like what level of sensitivity they wanted, because there's a trade-off with the amount of testing that's done. We'll do a lot of testing to capture, but there is a point where there's too much testing. So this was actually what we've been sharing with medical directors to say, for your particular ED and your particular clinical challenges, you can select various levels of sensitivity, but there will be a consequence in terms of the number of testing that's done. Does this mean that you upstaff on the front end in order to handle the testing, or does this mean that there's a certain level of testing that is operationally infeasible and not possible? But with that comes the idea that there will be misses, and we need to be thoughtful about how we handle those as fail-safes. So thank you for being available to hear some of the work that we've been doing. Also very grateful for the opportunity to do this work, and we recently received a $3.5 million grant to continue this in a multi-center fashion. So we're looking forward to sharing those results as well.
Thank you. Up next, we have Dr. Henning Stehr. Dr. Stehr is the Medical Director of Cancer Informatics at the Stanford Molecular Genetics Pathology Laboratory. His research focuses on computational methods for clinical oncology applications, with a special focus on circular tumor DNA and molecular residual disease. Dr. Stehr.
Yeah, so it's my great pleasure to present the results of a research project we conducted where we use machine learning in the context of cancer diagnostics. This is a collaborative project between a number of colleagues and trainees from pathology, hematology, oncology, and biomedical data science. And I want to acknowledge my co-PIs, Dieter Gratzinger and Jonathan Chen. And I want to point out one extremely talented trainee. We had Miss Grace Kim that you see on the top left there, who was really elemental in driving this forward and coordinating between all these different groups of people we're working with. And she's now off to medical school. And with a project like this under her belt, she not only got offers from very prestigious schools, but she also represents like really that new generation of physicians, right, who grew up with all these technologies, right, and kind of involved from the beginning. So it's really great to see that. My clinical work focuses on cancer diagnostics. So I developed these next generation sequencing methods. And our workhorse method is this, what we call HEME-STAMP. So STAMP stands for Stanford Actionable Mutation Panel, and HEME-STAMP is the version of that is focused on hematologic diseases, myeloid and lymphoid. So this is a targeted next generation sequencing genome profiling assay. It tests about 200 genes and a number of types of mutations that are detected in a patient's tumor cells, and then these results are used to guide initial diagnosis, prognosis, and then also therapy selection. So this test is routinely ordered, for cancer patients at Stanford. And on the right side of the slide, you see a part of an example report. So at the top, there's just information about the specimen that was tested, and then at the bottom, there's the summary of findings. So and there's you can see there's a number of particular variants that were detected, and then at the bottom, there's a section of variants that where the relevance for the disease of interest is unknown at the moment, because this is all kind of still evolving. And so if we have a report that either has no findings whatsoever or has only these findings of unknown relevance, then we call this no pathogenic findings. That's important because that's how we classify it for the machine learning application. So we set out a number of years ago with the question, could we be able to predict whether such a test would yield a pathogenic result or not, simply based on the information that is known in the electronic health record system for the patient before even ordering the test? So can we already make a prediction of what the outcome would be? And we investigated, and that resulted in this initial publication here. So that was presented at the AIMI Symposium in 2022. And here we just so we used retrospective data, EHR data, and compared different machine learning algorithms to see which one might perform better with this data set. And we got some promising results. And with those preliminary findings, we got additional funding from the AIMI Center here, and we updated the question in not just, is it possible to predict, but how would these predictions compare to human expert predictions? And then also, can we deploy this in a live clinical environment and then make these predictions in a prospective fashion? And so this is the resulting publication that is currently under review, that is entitled Predicting Next Generation Sequencing Test Results in Real-World Clinical Settings, a Prospective Study of Human Expert and Machine Learning. So this is the design of this study. So there are 3 different arms in the study, and I will start at the bottom where you see, so we have our prediction model that we developed previously, that is trained on data in the electronic health record, things like prior diagnosis, prior test results, demographics, and prescribed drugs for the patient. And then we deployed that in Epic so that whenever someone orders the HEME-STAMP test, it would trigger a real-time prediction using this prediction model. And then we store the result in a database. And what also happens is we are sending an email. So if you go to the top of the slide, the top arm there, we send an email to the ordering physician, so the one who entered the order and ordered that for their patient, and ask them to basically give their best estimate of what they think the likelihood is that this will yield a pathogenic result or not. And then furthermore, the third arm in the middle is like that we had like an independent clinician who would perform chart reviews, who has not actually seen the patient, but would just look at what's available in the electronic health record and also give their predictions. And so this is how we're able to do these real-time predictions. So it's using this deployer framework. There's a publication at the bottom that you can look up for details. So initially, so on the top left, we developed our model using the Stehr database, which is like a 24-hour delayed copy of the EPIC system. So that's the retrospective data that was used to develop the model. And then the model is deployed as a serverless cloud function. And then we interact with EPIC, through this API and this inference engine that, can then run basically our prediction model and then store the results in a backend database. And at the bottom, you can see that, so we use this best practice advisory mechanism in EPIC to actually trigger the prediction. So you may know that, it's basically telling you maybe you should order something else or so on, but this is a silent deployment, so you don't get to see it, but it's like the mechanism that enables EPIC to kind of trigger actions, when someone orders a test. So what did we find? So this is basically the performance comparison for the 3 different arms. And these values are like, area under curve, of the prediction accuracy. And so what you can see is that the best performance is the actual ordering physician, but the prediction model is very close in accuracy, like in this data set. And most importantly, if we combine the predictions, and you can read about the details how that is done, it's currently a relatively simple way, but if you combine the predictions, then you actually outperform all the individual predictors, right? Both the human and the machine. So that's kind of the promising application of that. So to summarize this, so we built this machine learning model that can predict whether a next generation sequencing test such as HemeStamp yields like a pathogenic finding. And then we evaluated that in a prospective manner compared with human experts who are directly involved in care. And then we also demonstrated how this can be deployed in a live clinical system. And I think this really can serve as a framework for similar applications, some already ongoing and some in planning stages. For example, the most obvious things is like, other tests, and my co-PI, Dr. Chen, he has done extensive work on the predictability of high volume tests, like such as blood tests. So this is just kind of another example of, the kind of things that we can do with prediction algorithms. So thank you very much.
So we've heard from folks who are developing models. We've heard from folks who are paying for models. You all are the sort of clinician-facing group, or the clinicians that are putting these models into practice. We know that models themselves don't make people healthier. Maya and Fatima, you guys both gave examples of projects that have sort of taken this to the next level and implemented this work. Could you maybe talk to some takeaways or generalizations of what elements beyond the model are necessary in order for these things to be impactful?
Sure, that's a great question. And as the model that we're using now, I'm sure it's evolved. We're probably using a much later version. So I don't think, and I've said this many times, that the model itself is the innovation. It's the first of all, using it in useful ways in clinical settings where it's acceptable and approachable. A couple lessons. We have a whole series of projects around this coronary calcium. And it's different depending on the different use case. What are you going to do with this information? So one thing that we know is that as a cardiologist, I think it's great that people that are at risk are started on preventive therapies. But whose responsibility is that? Right, we're notifying the primary care doctors. They have a lot on their plate, right? So you have to think about all the different stakeholders who are potentially involved in this to ultimately help treat a patient. That's why our team is so, I mean, I don't think even everyone that's on our team was on that slide, because everyone needs to be in that room to be there to have that discussion, because we all have blind spots. Again, to me, everybody in this room should be on a statin. It's the greatest thing ever, but maybe that's not accurate depending on the patient, depending on the clinical setting.
I'll maybe add to that as well that when our team started working on really this prediction concept, if we really want to have a predictive model embedded in care to improve the quality of what we're already doing, we were really thinking about the innovation and the intervention was the model itself. And it became really apparent that the model was, it was the mathematical piece that was a far more complex pathway of linkages. And it's actually led to us realizing that a lot of the science of it working had nothing to do with the model at all. And so we really had to separate our projects where one side was really mathematical, computational, really improving the model. And so everything from, is logistic regression enough? Is using different forms of machine learning better? If I can explain it to the CEO and he gets it, I can explain it to the leadership for nursing. That has more value than having a black box approach, even though the performance might be slightly different. Really trying to weigh in those factors with regard to the model and the utility of getting it into the system. The other side was about the workflow, and so really needing to test. One of the things that I remember from my training really early was just because you do the same thing in two different rooms doesn't mean you get the same outcome. And so if we're creating models in sort of testing simulation environments with statistical programs and machine learning programs, once you put it into an electronic health record with dynamic data and missingness and messiness and changes, that it doesn't mean that you're going to get the same outcome, and needing to test that translation along the way. And who to engage on that side has been really important. And not to mention that that's just the informatics workflow. There's the clinical workflow that maps, and not everything that happens clinically maps to the EHR. So if you need to create things in the EHR to map, because now we're talking about specific things, the products weren't built for the specificity. So I think really being able to link all that together ended up being 90% of the work. I'd say that's that part of the work of working in the clinical environment with the informatics and clinical side has actually been a lot more work than working on the model itself.
When you talk about working in the clinical environment, hospitals have been trying to get better for decades. We call it QI, quality improvement, process improvement, PI. What are your thoughts on what's the relationship between QI and AI? Is AI sort of a piece of the QI puzzle, and are us as AI practitioners, are we sort of doing QI work?
Yeah, I mean, I think so. Specifically in molecular diagnostic, there's actually a long history of prediction models of genetic markers and, kind of varying range of, sophistication. But it's basically only another step in that direction, right? We're just using different technologies, but the ideas have been out there, and I think people, kind of are used to using them in some context. But maybe connecting that back to the previous question, right? So there are really these different layers, right? So it's like there's a huge body of work out there of just taking some data set and show that we can infer something from the data set. But that's really kind of only, and that results in some research paper. Right? So now the next step is that, we have been trying to put that in a clinical environment, right? To deploy that in the world. And that alone is like kind of a big task, right? To just get the resources and get it in the right place. But even then, the real thing is to make a difference, right? What is the intervention, and how should people use that, and who should be using it, and under what circumstances? And I think that's still to be done, but at least we're now approaching that. We're now able to address that, right? And it's really great to see that these prior presentations here, they are actually now addressing this real question that we're having.
The only thing I'll add to that is that I was talking to Dr. Larson about this. This AI for our work is really a tool for population health. We could physically look at every single CT scan that has been done. It's just the manpower needed to do that is just not practical or feasible. And we're trying to optimize the way we use population health digitally within our system. But it really is a tool set. And again, a lot of this is just building on what we already have, the QI frameworks we have from regular, earlier epochs of AI.
And I might add to that, that I really think about it maybe in two buckets. There is a way that we do work currently, and it can be optimized. And I do feel like that falls into the quality improvement bucket, quality assurance as well. The other part of that too is, I'm a huge proponent of extending that to the clinical impact, really the area of clinical research, which is where my work primarily is, that it's one thing to improve processes and it's one thing to improve workflows. It's another thing to show that those new process improvements and workflow improvements actually result in improved clinical outcomes, and being really specific about what about a patient's health state is going to change as a result of this new communication tool, this new AI algorithm being embedded into practice. It's a lot harder. It takes much more time, but I do feel like it's the whole point of what healthcare is about. I think we sometimes can forget that in the excitement of the software and the technical innovations and also all the players who end up coming to the table, and we share intellectual know-how and build cool things. But does it work is a question that I think has multiple levels to it. And really the idea that there's the quality improvement, but there's also the clinical improvement. And again, it's hard and it's slow. So I think there's that side of it too that's really important to take into it. The other side is I think AI does offer the opportunity to rethink how we do work, rethink how we practice, rethink who's involved, and do we even need to be involved, or can an algorithm take over what a team of 10 people might have been able to do, and we can actually change healthcare delivery. So I think sometimes on the clinical side, we tend to be very used to how we practice and not as creative about thinking about how else we could be doing the same thing. But I do feel like there are many folks who are on the more creative engineering side and design side that are very good at doing that, and the partnerships can be very valuable to think about what the future could be.
Wonderful. Now we can open it up to you all. Folks from the audience would like to ask questions, either in person or online.
I'm going to ask a couple of questions online. One of the questions is there a public system to report adverse events for using AI/ML in patient care? And the second question is about healthcare is very conservative in adopting new technologies. How do you convince the C-suite to adopt new AI products?
Public reporting, and how do you convince the C-suite?
So I'll sort of answer that. I think the reason that you can't just say this algorithm is a good idea, just use it in clinical practice, is exactly for that reason. You need to study it, because sometimes this is not just for AI, but it's for all health-related projects. It seems like a good idea, but there's unintended consequences. So for example, for our work around identification of people at risk of heart disease, what if all these individuals end up having not invasive procedures that they don't need, there's stress and other things happen, or they have so much else going on that this is really irrelevant for their health? That's also a problem. So you need to study that, and that is why we are testing hypotheses and doing it in a very systematic way with safeguards for the patients involved in this. And then I'll let you answer the C-suite.
Well, I will say that one of the things that's unique about AI interventions in health is typically, and I'm going to speak from the clinical research framework, if you have a new drug or a new device, you deploy it, you implement it at the patient level. So you go to your clinic, and you often have friends who have clinics like yours or clinics adjacent to your care practice area, and you can set up protocols at that level. What's different about AI is that the implementation is at the system level. And so you're now tinkering with your health systems, information systems, and there's a lot in terms of you add one thing, what does it break? You add one thing, there's consequences at that level in order to get down to the patient at the individual level. So for many of these products and innovations, there's multiple customers, if you will. There's the patient, of course, but often is on the receiving end of a system that's a little bit of a black box to them. There's a provider whose practice is shifting. There are multiple providers, often in team-based settings, and so they all have different roles. Not to mention the hospital practice system itself, from a clinical perspective, is now doing things differently, and then the information technology side as well. And so really learning the language and the priorities of all those groups ends up being like the bulk of the work, because nothing will move forward to practice if everybody doesn't understand what's happening, understand the benefit of doing it, as well as you learning about the cost and building that into the pitch for what you're trying to propose. And I think doing all of that ends up making it a lot of work. Often the algorithms then get retrofit and retasked in order to account for all of that. But I think when you're able to answer all those questions and present it to leadership, the spin's a little different for each group. But the C-suite has their priorities, the information technology groups, and there are multiple levels there as well, from the programmers to the leadership. And on the clinical side, the same thing. But I think understanding their priorities, addressing their priorities, and often it takes experimentation and testing, as Dr. Rodriguez was alluding to.
But I think we're in a good place if we just apply the same principle of evidence-based medicine that we have used in other contexts, right, when we introduce new technology. So there are some variations here, and you have addressed some of the specificities, but yeah, I think that can be the general approach.
Hi, my name is Al. I have some questions about provider perceptions when it comes to using these models. How important is explainability when it comes to models as opposed to getting like a black box output? Do they want to know like what features are being used to make these decisions, or are they comfortable with just getting an answer from a model?
I mean, I'll maybe take a stab at that. I mean, from my perspective now, I'm speaking as like an N of one. There are lots of tools in medicine that we use and don't really know how it works, and that's okay. Because I think what we need to know is have trust that whatever you say it does, and that I know how to use it. So an example that I give often is like an MRI machine. I know generally how MRIs work. I learned about it in medical school. Hydrogens, they spin in different directions. There's a magnet, cool. What I really need to know, and I know how to read the images. I understand like T1, T2, flare. But what I really need to know is when do I do an MRI, and when I do it for that indication, do I get what I'm looking for, and is the output going to help me make a decision for the patient's clinical course? And if there's clarity around that, I think that's what, when people talk about transparency for clinician use, I think that's what we often need. Often with our, my team's tech partners, what we'll get is an explanation of technically how the tool works on the inside, which I think is less relevant. I think replicability, reliability, and assurance that you're going to get the output that's then going to be relevant clinically is maybe the transparency that's needed on the clinical side, which is slightly different.
I agree. I think that, again, speaking from my physician lens, it's about the transparency of how does this perform, what is the ground truth for whatever the model is, for what you're trying to show, and maybe less so for non-technical physicians about what are the features that matter in the model that yield the result.
So I guess in addition to that, so what you're saying is they need to trust the model. So what about the use of proxies for health outcomes for validating these models? How comfortable are providers knowing that many of these models are used using proxies for health outcomes as opposed to?
And again, for example, a lot of our clinical trials in cardiovascular disease are outcomes based. So they're like, do you die? Do you have a heart attack? Do you have a stroke? But a proxy for that would be like LDL cholesterol. We're lowering the mechanism of a drug. So what do you mean by proxy?
So in your case, the proxy you used was statin use. So that was the outcome that you were looking at, as opposed to like LDL or health outcome.
Right. So I think it just depends on where it is on the causal pathway. So LDL is causally linked to heart disease. So that's the problem we were trying to solve in that case. If I was trying to do an AI algorithm, and that is actually an improved outcome, like by itself. But if you're trying to, for example, for Dr. Yiadom's example, if you're trying to prevent heart disease deaths, that's the ultimate outcome, to prevent heart attack mortality and morbidity. But her proxy is, are they getting an EKG within a certain amount of time? So it's all in the pathway, but that's part of our normal clinical care pathway too. So that's no different than a clinical visit where I would do the same thing.
Yeah, and I would agree. I mean, I think, often, in the world of evidence-based medicine, which is really that drives innovation on the clinical side, the question is, how good of a proxy is it for what we really want to look at? And so, like in the case of my models, we use ICD-coded final hospital diagnoses. There's a margin of error. But one, we've looked at all different possibilities. That's the best thing that we have. And we've quantified the margin of error. And we build it into the models to be reactive to that. And we actually look at the charts of the patients. We literally look at individual charts and read through them to see how close was the error margin. Would it still have been helpful to pick up those patients? Harmful to pick up those patients? What would that do for our testing rates? And those research studies have given the confidence for that proxy being sufficient for people to want to use it. So I do think that lens of, is it a good enough proxy for the problem? And how do you gain the confidence in whatever you build or whatever's being built, focusing on that proxy being legitimate for however it's being used. It ends up being complicated, but I think the comfort level really gets down to the devil in the details. But I think the concept of using proxies is not something that I would perceive clinicians are against. It's just a matter of, again, the devil's in the detail.
Thank you.
Great talks. Another great source of potential evaluation. All patients who undergo radiation therapy for chest wall radiation, breast cancer, you got scans sitting there, and so I think you could interrogate those. Second, I want to know about the medical legal aspects. If I had a scan done for another purpose, and you missed great calcifications, and now you tell me 3 years later boy, you're at risk, and now you find out I have triple vessel involvement, I'm going to be a little upset. I'm not going to say, thank you. I may say thank you, but I'm going to say, well, why was it missed 3 years ago? Have you looked at the medical legal implications? Has that been a concern?
Great question. So our patient representative who's part of our group, Doug, that's the reason he's part of our group. He's so passionate about not having been told. The reality is that a lot of this information is in the reports. So like I think 96% of the patients in our first study about 96% had some mention of coronary calcium in them. But again, why are people getting the scan? It's so confusing, it's so complicated. Does it get bumped up to the report? Is it seeing the image? Is it having the guidelines? And this is not just about calcium, right? It's all about all sorts of incidental findings. And the reality is that there's so much information in these scans that are done every single day for other reasons. And there's sort of a balance, right, between what's actionable. I think that the beauty of atherosclerosis is that it's very actionable, and it could potentially start those conversations.
I mean, there has been a whole issue of one of the radiology journals on how to deal with incidental findings in general, and I think that still remains a very important unresolved issue. Thank you.
Thank you.
Yeah, and I might add that we often see incidental findings as like a problem we have to deal with now, but I think some of the really fantastic work that was spoken of earlier today, and I think mentioned again, is the idea of go looking for the incidental finding because it's a precursor for future disease, and that's just a level of computation that is difficult to do at the individual level. The scan was done for an indication, but I think there's an opportunity for AI to be helpful in that space to reuse past problems, information for future problems.
Thank you.
Hi, and my name is Frank Notaft. I'm a bioinformatician working in precision oncology, and wanted to riff on the kind of patient-centric side of this. For us in medicine, we're often used to working with those proxies, those surrogate endpoints, but our patients may not necessarily be used to working with them. And as we kind of move into this world where AI will surface more data, more incidental findings, more actionable mutation calls, where a patient has to make a very subjective choice between a medication that might extend their life by some amount of time, but might come with a quality of life hit or an increased financial out-of-pocket costs. How do you think about transparency as we look to roll that out to patients in the clinic?
That's a great question. And I'll say I'm particularly challenged in my area of practice in the emergency department because we have short relationships with our patients, but we have intense relationships with our patients, where often we are having these end of life and goals of care discussions, teeing them up for the following team that'll come up behind them. So I feel like even though we don't have the longitudinal responsibility for carrying the load and the burden of whatever that decision might come with, familiarity with having to have the conversation. And I do think that there's a paternalistic angle in medicine that I think is historical. So you're sort of touching on that a little bit too and bringing it into the AI space around we're putting our judgment into what the output should be and whether it's okay and it's good. But there is this other piece that's been often forgotten, which is what patients' preferences are. And I do think the framework of shared decision-making is important. And how do we replicate that with AI? I think is tricky and disease-specific, but particularly relevant for oncology.
Agree, and I think we're learning this from our focus group work now in our qualitative data. And we even have it in our notification. We've changed the language, so now we no longer say at first we were like, "You're at risk for having a heart attack," which was probably very effective. But one of our patients told us he almost dropped dead at Costco just from reading the notification. So that's not good, right? So now we're trying to balance that acceptability and patient preferences. And again, I think the right answer for this is that there's not for one patient. It depends. We have some patients like Doug who are like, why didn't anybody tell us? You could imagine a different patient saying, I was dealing with cancer. Like, that's the last thing I want to hear right now is about another problem I may have, right? And having to follow up and all that piece of it. So I actually think that there's huge promise, and that's a great point that you bring in. And we have the health system perspective, the clinician workflow perspective, but how about the patient voice? And the patient voice should be in the AI algorithm design stage and the incorporation into the clinical workflow.
Thank you very much.
Wonderful. Last question for me, from each of you. What concerns you most about AI in clinical care?
I think if everything is conducted with the experts in the field, like we have seen now, then I'm very optimistic. But there are these obvious concerns about financial pressures and then decision makers who may not understand the limitations of certain technologies, right? That's a dangerous combination.
I mean, I'd say my concern is also my excitement. I do think that the innovation is being driven from outside of healthcare about what we could do inside of healthcare. It's computational, it's technological, but where I worry is that the actual context with which the technology would be applied is often lost, and that we are part science and part art in medicine, and that the art perhaps can be coded, but that human touch, that interaction, that almost in some cases spiritual experience of being sick and being cared for, can't always be coded away, and that part needs to be part of the conversation as well. And so I think my hope and my fear as well is that my hope is that the ethic of what medicine is here to do and really what it means to bring health is at the center of conversations around what the technology can do. And I do fear that it gets lost at times, but I'm hopeful that folks at forums like this will be leading the way for that to be less of an issue and much more of an opportunity.
I agree with all that, and I also worry about just health equity. What are we doing for all groups? Who's in the data? Who are we helping? And especially when it comes to outcomes. So if we identify something, we have to be able to make sure we provide the care that our patients need for across all populations, so that no one's left behind.
Wonderful. Thank you all so much for your participation, and thank you to our panelists. Really great discussion. Appreciate it.